Hi, my name is Lindsay Wells, and I will be discussing the mid-range theory, peaceful end of life for nursing 5120. This theory has two authors, the first being Cornelia M. Rulin, who received her PhD in nursing informatics in 1998 from Case Western Reserve University in Cleveland, Ohio, where she is currently a director of the Center for Shared Decision Making and Nursing Research at a university hospital in Norway. She also serves as the adjunct faculty at the biomedical informatics at Columbia University in New York, where she established a research program with regards to improving shared decision making and patient provider partnerships in healthcare, along with the development, implementation, and evaluation of informational systems which support the issue. The second author is Shirley M. Moore. She received her PhD in nursing science in 1993 from Case Western Reserve University, where she is currently the Associate Dean of Research and also a professor at the Case Western Reserve School of Nursing. She utilizes her desire for nursing by educating students on all levels of nursing theory and science, and has established a program of research and theory development which addresses recovery after cardiac events. So this theory was developed in Rulin's doctoral theory course, where students were required to obtain a mid-range nursing theory from their choosing, where Moore contributed as a part of the faculty. Rulin chose to develop this theory based on the recent previous assumptions, which focused on development for clinical practice for peaceful end of life in regards to cancer patients in a surgical gastroenterologic unit from the Norway University Hospital. The realization of the crucial need for developing a mid-range theory for the peaceful end of life that connected nursing interventions to patient outcomes was established, where it was then enhanced with collaboration and contribution from Rulin and Moore. So this theory validates its classification as a mid-range theory by focusing on terminally ill patients and addressing the standards of care based on empirical evidence by incorporating the relationships of nursing interventions and patient outcomes related specifically to providing a peaceful end-of-life experience for patients and their significant others. So this theory experiences several clinical expert nurses caring for terminally ill patients on a routine basis in the surgical gastroenterologic unit in Norway, which exemplified the extreme lack of knowledge related to implications for quality of nursing focusing on terminally ill patients. So there are two theoretical frameworks, the first being Donabedian's model, which emphasizes the importance of structure, process, and outcomes as crucial components in quality assurance. So here we have structure, process, and outcomes. The theory depicts structure as the family system with the terminally ill patient and their loved ones, utilizes process to establish positive nursing care interventions and relationships with terminally ill patients and their families, and then it utilizes the outcomes by addressing emotional and social aspects related to the standards of care and peaceful end of life from patients and significant others. So the second theoretical source is the preference theory by Brandt, and it just illustrates the quality of life as achieving satisfaction for patients through clinical assessment by providing relief of symptoms and ensuring optimal social relationships. So this empirical evidence was also obtained from Rulin and other expert nurses, consisting of practitioners with a minimum of 5 years of clinical experience in providing nursing care for terminally ill patients and their families, which in part gives them, the expert classification. So here are the primary sources. The Peaceful End of Life Theory was written by Rulin and Moore, and it titles Theory Construction Based on Standards of Care, a Proposed Theory of the Peaceful End of Life. It was published in the July-August issue of Nursing Outlook, Volume 46, Number 4. So now we have the nursing meta-paradigms, which are speculative assourcement and consist of the human being's environment, health, and nursing, and as a result of obtaining standards of care for the peaceful end of life theory from expert nurses addressing the problem of clinical practice, only the meta-paradigms concepts of nursing and person were identified. So now we have 5 conceptual definitions, and we're also going to incorporate the theoretical assertions to go along with each conceptual definitions. The first one being the conception of not being in pain, which is having the experience of pain by remaining free from suffering and misery. And the theoretical assertion would be monitoring and administering pain relief while also utilizing pharmacological and non-pharmacological interventions aid in the concept of not being in pain for the terminally ill patient. These can also be included as nursing interventions, the theoretical assertions. So the second one is concept of experiencing comfort, which is relief of distress resulting in a state of ease and peaceful contentment. And the theoretical assertion would be by facilitating nursing interventions of prevention, observation, and the release of physical discomfort, providing rest and relaxation, and avoiding complications will ultimately establish an experience of comfort for the terminally ill patient. The third, experience of dignity and respect, is perceiving a state of autonomy and worth, including fulfillment of being respected and valued as a significant individual with their integrity intact. In order to implement the concept of experiencing dignity and respect, the nurse must include the patient and their significant other in the decision-making process, providing empathy, dignity, respect, while also fulfilling the patient's expressed needs and wishes. The fourth concept is being at peace, which is a feeling of calmness, harmony, and contentment without anxiety, worry, or fear. And the theoretical assertion for being at peace, interventions contributing to an individual being at peace, consists of providing emotional support for the dying patient and their loved ones, assessing a patient's need for anti-anxiety medication, establishing trust, providing guidance with regards to issues, providing physical support for another caring person if the patient so desires. So the final concept is a concept of closeness to significant others, and it is the affection including a feeling of personal, emotional, and physical connectedness towards other individuals caring for the terminally ill patient. To ensure closeness to the patient and their significant others, participation of the loved ones in the care of the patient need to be facilitated. Being attentive to significant others' questions, worries, and feelings of grief, while also providing opportunities for family closeness, will aid in the implementation of establishing closeness with significant others and other persons caring for the terminally ill patient. By fulfilling the notion of not being in pain, providing comfort, establishing dignity and respect, ensuring peace, and providing closeness to significant others, aids in assisting deliverance of a peaceful end-of-life experience for the patient and their family. So now we have two major assumptions, the first being the recognition of an individual's emotions towards their end-of-life experience needs to be acknowledged as highly personal and individualized. And the second major assumption is holistic nursing is essential in providing a peaceful end-of-life experience by establishing interventions while maintaining patient autonomy. So here's a list of the theoretical assertions. We've already gone over these, except for the last one, and I'll read it to you. The last theoretical assertion combines the concept of not being in pain, experiencing comfort, dignity, respect, ensuring peace, and establishing closeness to significant others, ultimately contributes to a peaceful end of life for the terminally ill patient. So here is a schematic from Ruland and Moore. And we've already gone over it. It just states the peaceful end of life, and then it gives the 5 conceptual definitions of pain, comfort, dignity, respect, peace, and closeness to significant others. And then below each of those are the nursing interventions or the theoretical assertions. And then by acquiring information from both literature reviews of evidence-based practice and expert clinical practitioner knowledge, the theory can include both inductive and deductive reasoning. So deductive logic utilizes extensive rational statements and assertions to form specific outcomes and conclusions, while induction focuses on specific situations and emerging general theoretic statements. The standards of care focus strictly on empirical evidence describing the practitioner's roles and accountabilities, while depicting the connection between process and outcome theory. Pertinent clinical knowledge, evidence-based research, and interpretation of standards of care have provided a valid, direct, and logical establishment of practice and theory. And then there were no specific flaws that were identified within the literature, but the theory may require additional empirical support for the development of relationships and further influence regarding nursing practice, education, and research. So here we have research, and the theory has established acknowledgement for obtaining crucial components for the care of the terminally ill patient for multiple individuals and authors worldwide. Kong Suwan and colleagues developed a conceptual model based on the peaceful end-of-life experience in patients in Thailand, and also in Quebec. The theory was utilized to explore the perceptions of a peaceful death in patients residing in rural communities. So now we have education, which is the theory and the holistic nursing care for patients and their families, which has been incorporated into nursing curriculums for multiple decades. And then in practice, Baggs and Smith depict the importance of peaceful end-of-life theory and the implementation of discussing the DNR status of with terminally ill patients and their families. Kirchhoff utilized the theory to establish important concepts in order to provide an optimal environment for families and terminally ill patients in the intensive care unit setting. So now we have implications for the advanced practice nurse, which is to strive and obtain optimal patient care while maintaining adequate patient autonomy. Advanced practice nurses are liable for recognizing and providing terminally ill patients and their family health care services for hospice and end-of-life care, which is initially difficult for any individual and their family to accept. So here we have a scenario where it's Mr. Garrett. He's a 54-year-old Caucasian male who's presented with an abnormal stress test during a routine healthcare visit. He is currently employed. He has 2 sons and a wife. For what seems like months on end, Mr. Garrett's wife has noticed that he is just not himself, but becoming more easily fatigued than usual. Once the results of the abnormal stress test are discussed, additional laboratory tests are performed, which reveal a hemoglobin of 6, where Mr. Garrett reports to the physician that he has been experiencing chronic fatigue for quite some time. He is admitted into the hospital, and after extensive GI interventions and multiple blood transfusions, CT of the abdomen is performed to exclude any reason for the blood loss and decreased hemoglobin. A massive tumor is discovered in Mr. Garrett's small intestine, measuring 12 by 11 by 10.5 centimeters, and invasive abdominal surgery is needed to biopsy and remove the tumor. After 24 hours of worries, concerns, and questions, the biopsy report reveals a rare, aggressive, stage 4 cancer that has progressed and migrated to almost all parts of Mr. Garrett's body. The surgeon consults the oncology physician and discusses treatment options, but unfortunately, there are no treatment opportunities, and Mr. Garrett, along with his family, decide to just go home. Mr. Garrett's request is granted, and the advanced practice nurse is to oversee his end-of-life care. The advanced practice nurse is thorough in discussing concerns, questions, and requests with Mr. Garrett and his family. The advanced practice nurse discusses end-of-life care with the hospice nurse, and together they provide comfort and holistic nursing care for Mr. Garrett and his family. The advanced practice nurse is able to educate Mr. Garrett's family on comfort measures, pain prevention interventions, and the ability to provide dignity, respect, and peace while maintaining a family closeness. After a few short months, Mr. Garrett passes, and the advanced practice nurse is content in knowing that Mr. Garrett experiences a sense of comfort and peace without pain or suffering. So just to sum up the peaceful end-of-life theory by Rulin and Moore, it focuses on implementing holistic nursing care by incorporating the relationships of nursing interventions and desired patient outcomes related specifically by providing a peaceful end-of-life experience for the terminally ill patient. It ensures a peaceful end-of-life experience consists of eliminating pain and suffering, providing comfort, ensuring dignity, respect, and a sense of peace, all while establishing closeness to the patient and significant others. The standard of care is not intended to focus strictly on death and tragedy in and of itself, but to focus more on the present, assisting the patient with experiencing a sense of peace in the remaining time they have with their significant others. Thanks so much.